Let me just test the remote here and just make sure this is going to work.
Not working? No?
May have to have it advanced.
Okay.
So thanks for braving the weather here this morning and making it out. And hopefully this will be worthwhile. The Lupus Foundation is certainly something that I believe in strongly. I think patient groups are extremely important in terms of advocating the disease and in terms of furthering research and other efforts in that way. And today specifically we're going to talk about lupus and the skin. Go ahead to the next slide. So I'm a dermatologist, as mentioned, at the University of Utah. I'm a native of Salt Lake and graduated from the University of Utah Medical School in 2002. And then my training took me to Dallas, where I really became interested in lupus at UT Southwestern. And I'll talk about that a little bit more later. But then skiing really brought me back to Utah. But I'm up at the university, as mentioned, and that is not me in the picture. Next slide. So today we're just going to talk about a few things. We're going to talk about the skin. I want you to start thinking about skin before we talk about lupus and the skin. So then we'll talk about skin lupus and quality of life, which is always a big topic for patients, and different types of skin lupus, what does skin lupus really mean, and then different treatments, of course, you want to hear about. And then probably the most important thing, I think, is to give you some time at the end to ask any questions you have about lupus and the skin. And so just being involved in other patient groups in the past, I find that often people ask questions and that generates more questions, and that often is where you get the most benefit. So certainly we'll give you some time at the end. If there's anything, however, during the presentation that I talk about that doesn't make sense to you, if I use language that doesn't make sense to you, please raise your hand, stop me, and ask a question. This is small, informal gathering. So in terms of skin, as you've heard before, the skin is the largest organ in our body. If you were to remove all your skin and put it on a scale, it would weigh about 20 pounds. Okay? So I'm not advocating that as a quick weight loss measure, but it's quite a bit of our body weight. People obviously spend a lot of time and money thinking and doing things for their skin, particularly women. Put on makeup, do hair, which is an appendage to skin. We spend, as a country, billions of dollars on skincare products every year. And the reason that is because skin is our most visible organ. So that's the way we present ourselves to other people, is our skin. And you can't open up a women's magazine without seeing commercial after commercial for skincare products trying to convince us that any blemish or wrinkle on our skin is bad, it shouldn't be there. So the skin is certainly a big part of our life. Go ahead, next slide. So dermatology is just the study of the skin, and dermatologists are physicians who have done extra training in terms of the study of the skin and how to manage skin diseases. And that includes just the hair and nails as well. Some people don't always think about that. But hair complaints are one of the more common things people come to the dermatologist about. We'll talk about hair and lupus here later on. So this is probably something that everyone has seen at one point during school, but just as the sort of a model of the skin. If you take out a little section of the skin and look at it, you'll notice that there's three layers. The epidermis, the top layer, the dermis is the middle layer, and then the subcutaneous or sort of fat tissue underneath the skin. And go ahead to the next slide. So this is a close-up of the epidermis, and there's two main cell types. There's this sort of pink cell with the blue center, which is called keratinocytes, and that's what makes up most of our top layer of skin. And then this sort of greenish-looking thing here is what we call a melanocyte, and that is what gives our skin pigment. So what it is these little brown pigment packets that go up in the skin. And we all have the same number of melanocytes, but different people, depending on their ethnicity and their genetics, make different amounts of these little pigment packets that sort of determine our skin color. So next slide. So this is what's called the Fitzpatrick skin type scale. And this is quite important to dermatologists, but whenever someone comes in my office, I try to put them in one of these categories. And obviously this is the lightest skin. Usually they have light hair and light eyes as well. And these people burn easier in the sun or at higher risk for skin cancer. Go all the way to Fitzpatrick skin type 5, has very dark skin, dark eyes, dark hair. And their skin cancer risk is obviously much lower because they're protected by those little melanin packets in their skin from getting burned. All right, go ahead and next slide. So here's just a close-up of the dermis, the second layer of skin. You notice this is where a lot of the action is. This is where the hair follicles are, the nerves, the blood vessels, the different important things that run through the dermis. And if you get a cut just in the top layer of skin, the epidermis, it usually heals up without any scarring. However, if you get down into the dermis, that's where you have your collagen, and that's what remodels, and often if you cut deep enough down into here, that's when you're going to get a scar. And that becomes important as we talk about skin lupus as well. So this is the fatty tissue. This is just a microscopic version under the skin of what we call the subcutaneous layer. And that is rarely involved in lupus, but there are a few rare subtypes of skin lupus that actually involve clear down into the fat underneath the skin. So what is the function of our skin? Next slide. So probably the first and most important thing is protecting us, right? It protects us from the elements, blunt trauma, from anything from the outside. It protects our internal organs from damage. It also protects us, importantly, from germs, right? From bacteria, viruses. We didn't have skin, so people that get burned over most of their body, they don't die from the burn, they die from the infection that comes afterwards because their skin cannot protect them anymore from these invaders. Go ahead and next slide. So this is just a schematic of the skin and looking at the immune system in the skin. The immune system is actually quite complex in the skin. The more we learn about it, the more complex it gets. So the immune system is obviously our system in our body that helps us to fight invaders or bacteria and viruses, etc. So up in the top layer of skin, we have little, what you could call watchdogs, okay? So they're looking for bacteria, viruses, anything trying to invade the skin. And then they communicate with these cells down here in the bloodstream about what's going on in the skin. And if they need to, they send more fighters here to help fight off things, infections, and so forth. Now, this system is beautiful when it works well, but it's so complex that in some people it dysfunctions or has malfunctions. And that's really when you get inflammatory diseases of the skin, like lupus, psoriasis, eczema, okay? All those are caused by the immune system in the skin malfunctioning some, okay? And so instead of just doing what it's supposed to and fighting off infections, it starts to create inflammation when it really shouldn't be there, okay? And we'll talk about that more. So another important function of the skin is temperature regulation. You can't read this very well, but if you walk for an hour, you lose or you sweat about 0.5 liters. Okay? It's a fair amount when you think about it. So that sweat is obviously to help keep our body temperature down, regulate. We're all mammals, so we have to try to keep our body temperature the same for our body to function normally. And the skin is important in terms of helping do that. Next slide. So finally, sensation. This is something we don't think a lot about, but skin is quite important in terms of warning us of things that we may be coming in contact with which could be dangerous to our bodies. Certainly temperature, extreme cold, extreme heat, right? Okay. If you have a disease like leprosy, where you lose sensation in your skin, then suddenly you damage your fingers and toes, or diabetes when you get neuropathy. Your skin stops telling you when you're exposed to heat and cold, and you can damage yourself. Obviously, bugs are another thing that we've evolved over time. That sensation to feel something when it's crawling on you, so you brush it off so it doesn't bite you or give you a disease. Okay? These are bed bugs, by the way, and they are visible. Okay, they're quite small, but they're visible to the naked eyes. So now I want to transition to talking about lupus in the skin and why, if you have lupus or if you know someone with lupus, that it's important to know a little bit about how lupus can affect the skin. So, just a little bit of history. You may have heard some of this before, but lupus is Latin for wolf, as you may know. I think lobo is the Spanish term for wolf. And originally, there was a disease that's still today called lupus vulgaris. It was originally described years ago. It doesn't have anything to do with lupus erythematosus, the type of lupus you're here today. It's actually a form of tuberculosis. And there's one skin form of tuberculosis called lupus vulgaris that occurs on the central face that looks similar in some ways to lupus erythematosus, or what we're talking about today. And initially, physicians and doctors couldn't distinguish the two, really. And so when people would present with this type of skin change, they would call it lupus. Go ahead to the next. And people have speculated that the reason they used the term lupus was it looked like a wolf bite on the face. It wasn't until the mid-1800s that someone actually used the term lupus erythematosus. Erythematosus just means red, essentially. So this red version of lupus, and you can see this was the first illustration in a medical journal of lupus in the skin. And they described it as this violet or purple sort of change on the face, and over many months they describe that it can turn into sort of an ulcer that scabs and then thickens. And so as a dermatologist, I'll just point out that lupus, before anyone realized that lupus could affect your joints or your kidneys or anything else, it was first described as a skin disease. Go ahead, next slide. So, as we know now, lupus is not just a disease of the skin. It affects lots of different things. And there's a lot of different organ systems that are impacted by lupus, from the nervous system to your joints, to kidneys, heart, lungs. Okay, all those can potentially be affected by lupus. But there's 11 criteria that sometimes are used in clinical studies and so forth to determine whether a patient has lupus. And most of these studies will require that the patient has 4 of these criteria to meet a diagnosis for systemic lupus. Interestingly, there are 4 of the criteria that just involve the skin. So 4 of the 11 are somehow skin related. And so skin is certainly a big part of the overall picture of lupus. Next slide. Skin is the second most common manifestation of people that have systemic lupus, joints being first. Okay? So 75 to 80% of people with lupus at some point will have some skin involvement. So it becomes important. This is something that's important to me as a dermatologist. Many patients with lupus only present with disease in their skin. They don't get anything else. They don't get much joint complaint. They don't get CNS involvement. They don't get kidney involvement. They don't get anything but involvement in the skin. And so do these people have lupus? Well, if you look at them on their skin under the microscope, their skin looks just like the skin in people that have lupus. If you look at their skin clinically, in the clinic, just on their hands, wherever they may have skin lesions, their skin looks just like the skin changes of people that have lupus. And so we call these people these people have cutaneous lupus. And they're not, this group isn't necessarily well recognized by other physicians outside dermatology because they don't go and see a rheumatologist necessarily. They don't go and see a neurologist. They come and see the dermatologist. And this is probably a subset of people, when you look at recruiting people in the future to the Lupus Foundation, that probably are under-recognized, and yet they truly do have lupus. Go ahead. So this is the many manifestations of skin lupus. You can see that it can be quite dramatic, okay? And it often affects visible areas, right? So there's some skin diseases, like psoriasis you may have heard of, that typically occurs in covered areas, okay, often in areas that don't get sun, so under your clothes, whereas lupus is often on the face, hands, it's in areas that other people can see, so that really has a big impact on quality of life. So when we talk about quality of life in lupus, it reminds me of this quote from Victor Hugo: "To die is nothing, but it is terrible not to live." Go ahead. So there's not a lot written about quality of life in skin lupus, but there are a few papers in the medical literature. One that was of particular interest to me called "Concealing the Evidence: The Importance of Appearance Concerns for Patients with Systemic Lupus." And they interviewed 10 women that had systemic lupus, specifically about skin involvement. And they sort of noticed three themes that were kind of repeated in the patients. First of all, when they developed skin lupus, they became more self-conscious. Right? They were just more aware that other people were looking at them and wondering about their skin. They also started using more cosmetics and clothing to cover themselves so they would, quote, appear normal. Right? And then there was a risk of self-isolation and depression in these patients that had skin involvement. Go ahead to the next slide. So one of these patients, Jessica, this is just a quote from the paper. She said, "There's only certain places I go. I mean, I go to bingo. That's one place I can go on my own because I just drive, park outside, and I'm in. They know me now, but if my face is that bad, I won't go because you can't cover it up." Okay? So when you think about skin lupus, I want you to think about patients like Jessica, that it really impacts what they do on a day-to-day basis because they're very self-conscious about going out in public. Their joints or their kidney involvement, doesn't show when they go out to bingo, but their skin does. Okay, other people see that. So quality of life. One study that was just published this year in the Journal of the American Academy of Dermatology, they looked at 157 patients and they measured quality of life. And physicians have the standard scoring systems to look at quality of life. And so they can compare different diseases, right? And their conclusion was that, first of all, patients with skin lupus had a severely impaired quality of life. And the lowest scores were those that had involvement in the face and hair loss, okay, not surprisingly. Interestingly, patients with skin lupus had lower scores than people with severe acne, psoriasis, vitiligo, which is a pigment change condition that is quite striking. And they had similar scores to patients with diabetes and heart failure. Okay, those are patients with skin involvement in lupus. So, any questions about quality of life or anything like that before we move on? Okay, go ahead. So the next thing I wanted to talk about was how skin lupus relates to internal lupus or systemic lupus. That's always a question when I get a new patient that comes in with skin lupus. They want to know, well, how is this life-threatening? What's going to happen inside me? Do I have systemic lupus? Do I not have systemic lupus? And this window is really to reflect that the skin can sometimes act as a window to what's going on the inside. So what happens, what's visible on the outside of the skin in terms of lupus sometimes tells us about what's going on inside in terms of other organ involvement. Okay, next slide. So when someone comes in the office and they have cutaneous disease, just means skin disease. So if they have skin lupus, I try to put them in a category. Do they have very mild or minimal systemic disease, or do they have more severe systemic disease? And I see people all across the spectrum in terms of that regard. So this is sort of a take-home point here up top. The appearance and distribution of skin lesions in patients with lupus correlates with the risk of systemic disease. So the type of skin lesions you have, where they are, correlates with what the risk is that you're going to develop internal lupus. And go ahead, next slide. So I use the analogy sometimes that of snakes. Right? and everyone loves snakes. When you know, there's hundreds of different kinds of snakes, and relatively few are poisonous, right? Some snakes we easily recognize, right, as being poisonous. So go ahead and click once. So the king cobra has these little markings on the back of its hood here that we all recognize as being bad, right? Rattlesnakes, okay, they have this rattle. So when we see that, we know, boy, that's a poisonous snake, I'm going to stay away. Click on the next slide. Other snakes, it's a little bit harder to tell, right? Is this a poisonous snake or not, right? This is a coral snake, this red on yellow, which is poisonous, whereas this is a king snake that has very similar markings, but it's red on black, okay? So it's not poisonous. So the same thing happens with patients with skin lupus. Some patients present with this classic butterfly, right, malar rash that you've all heard about. And that is a sign that something is going on the inside. Okay? Almost 99% of patients who get that malar rash have systemic lupus. Go ahead and click on the next one more. However, there's a bunch of other ways lupus can affect the skin, and it's not always as straightforward how those ways correlate with lupus on the inside. Go ahead and click. So there was a physician named James Gilling, this is his picture, he was a rheumatologist and a dermatologist, practiced in the 1980s, and he was at my training program there at UT Southwestern. And he sort of devised this classification for different types of skin lupus and how they correlate with disease on the inside. Right? And I don't expect you to memorize this or remember it necessarily, but this is just the way that dermatologists approach patients that have skin lupus. So acute cutaneous lupus, which is, we'll talk about, subacute cutaneous lupus and chronic cutaneous lupus. We try to divide patients that have skin lupus into one of those three categories. And there are some patients that don't fit perfectly, they overlap a little bit, but that tells us a lot about what the risk is of developing internal disease. Go ahead. So acute cutaneous lupus is this, usually presents as this malar rash or this butterfly rash across the face. And a lot of times people mistake that for another skin disease called rosacea, which you may have heard of. And rosacea is this redness that occurs usually across the cheeks. And lots of times I get patients coming in who have been referred for lupus when they truly don't have lupus, they have rosacea. And I'll talk about in a minute here one of the ways we can distinguish that. You can also get a more generalized red eruption when you have systemic lupus, usually in sun exposed areas, the upper chest, the back, over the dorsal arms, over the hands, okay, it usually spares the knuckles. When people get these findings on their skin, again, it usually indicates that there's something going on inside. So here's this patient again. I know these pictures, when you're not used to looking at pictures of the skin, so it's a little shocking. But so again, here's sort of the classic butterfly rash, and I'm going to get in the way of the projector here just slightly, but you notice that it spares this fold right here. Okay, that's real characteristic of lupus skin disease on the face, whereas rosacea, that other vascular skin disease I was talking about, doesn't spare that area. Usually it covers there. So that's one of the clues you can look at. Go ahead, next slide. So moving on, this is the next form of lupus, subacute cutaneous lupus, which has a couple of different forms. One, it can form these rings kind of on the upper arms, chest, or back. And then another form that just is these little red scaly spots. And this, go back, well, yeah, go ahead, that's fine. So about half of these patients with subacute cutaneous lupus will meet criteria for systemic lupus. So half will and half won't. Most of the ones that do meet criteria have pretty mild systemic lupus. Okay? All of these patients are quite sun sensitive. Right? So it's a very sun sensitive form of lupus. And then chronic cutaneous lupus is the third type I'll talk about. That when you hear the term discoid lupus, which many of you may have heard of, discoid lupus is just a subtype of chronic cutaneous lupus. And these patients, we'll show you some pictures of, but there's some other forms like paniculitis, that's the type that affects the fat more, okay? Chilblains lupus, which affects mostly the hands and the feet, and then tumor lupus. Go ahead. So here's some examples. This is a discoid lupus in a Caucasian patient. It doesn't show up real well, it's kind of subtle, but she has these red lesions on the face here that are scaly. In patients with darker pigmentation, it often will be strikingly what we call hyperpigmented, so they'll get real dark patches of skin. And then over time in the center, it becomes more white and then sort of active on the border. And obviously, this is the type of skin lupus that often leads to scarring if it's not treated. We'll talk about that again a little bit later on. Next slide. So in terms of patients with this chronic cutaneous lupus, they have the lowest risk for going on to develop systemic lupus. If at the time they come to the doctor, if they don't have systemic lupus, then their lifetime risk is probably around 5, 10, maybe 15% of ever getting it. Right? And some of the risks that we look at, if people have these discoid lesions, if they have them below the neck, okay, most people get it just on the head, neck, scalp, okay, and those people have very low risk of going on to develop systemic lupus. If their skin lesions are more widespread, their risk is higher. Okay? Also, there's some lab tests that we do that tell us if they're at a little higher risk. And if you have questions about those, certainly afterwards, feel free to ask. So,
I think it just skipped.
yeah. Go back one. Yeah. Okay, so chilblains lupus, I mentioned, is this form of skin lupus that is affected by the cold. So it occurs most often, it starts out happening in the wintertime and then starts to last all year round. Patients get these red, sort of tender bumps on their fingers or toes. Less commonly on the ears, but that can happen. And about 20% of those patients go on to develop systemic lupus, but a lot of them never do. And it is difficult to treat, particularly in colder climates. There's a number of ways, we won't go through them, that lupus can affect the skin besides just what we call skin-specific lupus. So when you biopsy lupus, it looks a certain way under the skin. But there's lots of other skin manifestations that are more likely to occur in lupus but aren't directly related to skin lupus. Vasculitis, Raynaud's, who probably a lot of you are familiar with. Alopecia just means hair loss, and we're going to talk about the different types of hair loss in lupus. People get dilation of the tiny little blood vessels around their fingernails. Okay, that's one of the manifestations of skin lupus. Oral ulcerations, so ulcers in your mouth, okay, is another common finding in patients with lupus. And then sun sensitivity. Okay, those are all things that occur in the skin of people with lupus. So hair loss is one of the more distressing things for patients with lupus. And there's 3 different types I want to talk about. The most common type among those that have systemic lupus is just diffuse thinning of the hair. And the more active their the more active their internal lupus is, the more their hair seems to thin. And we call this telogen effluvium, which is just the type of hair loss. But it is often sort of on the top of the scalp, and patients that have severe lupus, they'll just lose their hair. It doesn't fall completely out usually, but just thins, and it tends to bother them that it's not as thick as they'd like. The second type is more patchy hair loss. So we get these sort of circular areas in the scalp. And this is similar to what we call alopecia areata, which is sort of an autoimmune type of hair loss. And this is usually reversible, that's the good news, and it doesn't scar. Okay. So it usually is something that is treatable. Okay. And then the last type of hair loss in the scalp is when you get these discoid lupus lesions, these coin-like lesions in the scalp, They can be localized or they can be more generalized, and they do scar. Okay? That does scar, so that's something you have to jump on. So you can get permanent hair loss in the areas where those lesions occur. All right. So when we talk about lupus activity in the skin and lupus, it's really important to have a concept of activity and damage. Right? So, and being able to, as a dermatologist, it's important for me to know when someone's skin is active versus damaged, because the way we treat them is very different. So activity, obviously, this is a nuclear bomb, okay, going off, and there's the damage afterwards. Right? Forest fires, active, that's damage. Okay? Spraying more water on this, right, is not going to help anyone. And so how aggressively we treat a patient's skin has to do with how much activity is going on at the time. The way we treat damage is very different than the way we treat activity. All right, go ahead. So these are examples of activity in the skin. And how do we know that there's activity going on? Okay, well, redness, right, is one of the signs. Scaling or crusting of the skin, right, that's another manifestation of activity. Often there's itching, okay, burning, right, those are symptoms that there's activity going on in the skin there. And you can see these are more discoid lesions we talked about. This is more that acute cutaneous lupus, the butterfly rash. And here is the subacute, that ring or annular type. Okay, go ahead. So these are pictures that are supposed to show more damage. Okay, so you see, and apologies, let me just see what this is showing up. That's pretty good. So you see, this is all scar here. Okay, there's a little bit of redness on the edges, but the center is just scarred. Right? Again, scarring in the center, a little bit of activity on the edge. This is just scar, okay? Just brown and white, right? There's not much red in there. Again, here, mostly a little bit of activity. So, signs of scarring are when there's depression in the skin, that white change, okay, is scarring. You can also have what we call dyspigmentation, where the skin gets lighter or darker after you've had activity of lupus in the skin. And again, you don't necessarily treat this patient real aggressively now. Your window of opportunity is sort of closed for treating them in terms of inflammation. Now it's just damage. Okay, go ahead. So the goals of treatment, of course, are to reduce inflammation, prevent pigment change and scarring, and improve quality of life. So we think of when we treat patients with skin lupus as a therapeutic ladder, right? So the bottom are sunscreens and topical things. The next step up, and we're going to talk about all these in more detail. The next step up is animal aerial type treatments we'll talk about, then combinations of animal aerials, and then stronger treatments. So sun protection is obviously something that every patient with lupus should be doing, whether they have skin involvement at the time or not. Okay. So how do you protect yourself from the sun? It doesn't mean you can't go out, you need to lock yourself in a room. Okay. What it just means is that you need to avoid peak hours in terms of activity. So in the summertime, you don't want to be going out in the middle of the day and doing your gardening. You want to do it in the morning or in the evening, or you're biking or whatever it may be. You want to wear sun protective clothing when you're out. Okay? That may be a wide-brimmed hat. Okay? Maybe they really have made a lot of progress in terms of having nice clothing that is loose, that is easy to wear and comfortable, that still protects you from the sun. You want to use a broad spectrum sunscreen, something that blocks UVA and UVB, and you want to reapply it if you're going to be out for a period of time. No sunscreen completely protects you from the sun. So if you have lupus, if you think you're going to go out and sit at the beach all day and you're going to be okay just with sunscreen, that's not true. And then I do have some patients that are very sun sensitive, and you can get a physician's waiver to have more tint to your windows in people that really need it. That allows you, because we get some ultraviolet rays that pass through our windows, obviously. So we talked about topical therapy, and to be honest, topical therapy doesn't work that well for skin lupus, unfortunately. Okay? It doesn't work as well as it does for eczema or psoriasis. But it can help some. And topical steroids are sometimes used. What is more helpful are what we call interlesional steroids, which are when you inject the medicine into the lesion, because the activity is a little bit deeper in the skin. It helps quite a bit to inject those spots sometimes. There are some newer topical therapies that are not steroids that I've started using a lot more in my lupus patients. One called Protopic and the other called Elidel. You may have heard of them. They're not marketed for lupus. They're marketed for eczema mostly. Okay? But they're quite helpful for lupus on the face, where you don't want to be putting a steroid necessarily day after day and developing acne and thinning of the skin and other things. And so I think there definitely is a role for those in the treatment of lupus. Animal aerials are really the cornerstone, I think, of treatment of skin lupus. And why would we use animal aerial medicines for lupus? Well, animal aerials originally, the older versions came from this tree in Peru. Just the bark of the tree they found had some medicinal uses, and one of them was preventing malaria, which is this parasitic infection in the blood that doesn't happen here in the United States, but happens in Africa. And during World War II, we had obviously lots of troops from Europe and the United States over in North Africa, and they were taking animal aerials all the time. And some of them that had rheumatoid arthritis and lupus noticed that their skin was getting better, their joints weren't hurting as much. Okay? And people said, oh, there must be something to this. And since the 1950s, people have used animal aerials to treat lupus, rheumatoid arthritis, and some other things. The common ones used today are hydroxychloroquine, which is probably the most common one, or Plaquenil, chloroquine, and then quinacrine. Okay? And sometimes you can combine quinacrine with hydroxychloroquine or chloroquine to get more effect. You can't combine Plaquenil and chloroquine. You can't combine these two because this problem. Okay? The risk of animal aerials is eye toxicity. Fortunately, that's quite rare now. Okay? It's retinal toxicity. If we use appropriate doses and monitor that by going to the ophthalmologist periodically, if you're on one of these, then it really is something that we can prevent. So there's, for people, I would say that there's not great studies, but I would say about 75% of patients with skin lupus will get substantially better with sun protection, topical treatment, and animal aerials, those things, okay? That leaves then only about 20% of people who, despite those things, have active skin disease. Okay? And for those patients, there hasn't been a lot of great options. We have used a number of different medicines. Most of these are medicines that suppress the immune system in some way. Mycophenolate mofetil is also called Cellcept or Myfortic. It's commonly used by rheumatologists. It's also used in dermatology to treat patients that have more resistant skin disease. It also is used to treat lupus nephritis, or lupus kidney disease. And one that is not used by rheumatologists, but used sometimes by dermatologists, is thalidomide, which is, you may have heard of, it's a drug that back in the 1960s was pulled off the market because of birth defects. And recently, about 15 years ago, was back on the market. It's now used for multiple myeloma, a type of blood cancer. But it is amazingly effective in skin lupus. Okay? It has some side effects, but, which can be severe, so it's not for everyone. But for people who have very severe skin disease, it probably works better than anything. And then there's a number of what we call biologic therapies. When I say biologic therapies, just by raise of hand, who knows what that means, or does that make sense to people? Okay. So biologic therapies are, you're going to hear about more next hour, but these are a newer class of medications they're not given by mouth, they're usually an infusion or an injection. And they're usually very specific drugs that target certain parts of the immune system. And originally, these medicines were being used for other autoimmune diseases like rheumatoid arthritis, Crohn's disease, other things, and now they're starting to be used in lupus, which is very exciting. And there's some new studies going on where they're testing some of these. Go ahead, Lisa. So that's how we treat activity. Now, how do we treat damage? Well, the pigment change, you can put on bleaching type agents like hydroquinone topically or retin-A sometimes. Okay. Chemical peels and lasers have also been used in terms of treating the damage from skin lupus. But people are nervous about doing these things sometimes because they think that if your skin lupus isn't well controlled, that doing these procedures can trigger more active disease. And so you really have to talk to your doctor about if this is the right thing or not. Okay? The same for scars or depressions. There's fillers now that you can inject into the skin that help plump up the skin areas where there's depressions. People are doing some fat transfer. It's hard to find doctors who will work on lupus patients with skin damage, unfortunately. Prevention, people always want to know. Obviously, we talked about ultraviolet light, stopping smoking. Smoking has definitely been related to more active skin lupus. Avoiding infections. Oral contraceptives, avoiding them, and estrogens and progesterones. Still somewhat controversial, but something to talk to your physician about. Then there's a number of other medicines that can trigger lupus or make lupus more active. And so if you have lupus, before anyone puts you on a medicine, you need to talk to your doctor about that. There's one oral medicine for toenail fungus called terbinafine that is a frequent cause of flaring up lupus skin disease. So I see that commonly people get put on this medicine and their skin breaks out. So as I mentioned, there's a number of clinical trials for skin lupus that are ongoing. We have 3 right now that I'm involved with, and as of 5 years ago, there was absolutely nothing, and had been nothing for years. And so it's really exciting that the pharmaceutical industry now is starting to recognize that this is something that's worth investing some time and effort into, and that there's lots of people that suffer from lupus that aren't getting help from traditional medicines. And so I've got a couple of handouts up front I want you to come and grab when we're done. One just talks about clinical trials for skin lupus. The other one is a very nice article just about lupus and the skin that sort of reviews a lot of the things that I talked about. But I'm going to just open it up for any questions. Let's see, we've got a few minutes or so. I know you want a little break too before we next talk. So. Yeah.
Do you see very many patients with the oral
ulcers?
Yeah, like the canker sores and.
I see some definitely. You know, the oral ulcerations are much more common in patients that have systemic lupus, and I see some of those patients, but rheumatologists probably see more of those patients. And really, in terms of what's helpful for that, in real painful cases, I've injected steroids into them that can be helpful. Better control of their overall systemic disease is helpful, but it can be pretty miserable. I had a patient that was getting real bad sores up in her nose, and eventually he put her on that thalidomide medicine that we talked about.
I get a mouth, throat, and
And
esophagus.
esophagus, yeah.
Pretty much
So,
everywhere.
it definitely is a real problem. So, any questions, Jim?
How prevalent is the knowledge about detecting and proactively looking for lupus in skin patients? The reason I ask is because my wife, it was actually a dermatologist who finally found out what was wrong with her. For years, no doctor considered lupus, and we had 2 dermatologists that we'd gone through, and the third rheumatologist, because it was like, oh, that's rosacea. The third rheumatologist took a look at her and said, doesn't look like rosacea, it looks like you have lupus. That's how we found out she had lupus. So it was actually a dermatologist who ended up probably saving her life, actually. She later fell into a really bad flare, and had we not known, who knows what would happen. But it just seems odd that two dermatologists quickly wrote it off as rosacea. And my question is,
talk about what are the features of skin lupus, and so patients that don't, or dermatologists that don't see as much lupus, that they're able to recognize that a little bit easier. That's certainly one thing. I think that lupus, not just skin lupus, but lupus in all its forms, and you guys can attest to this, is often a difficult diagnosis in terms of it often takes several visits and several doctors before someone, because people don't always present in the classic way. I get a lot of people who come to my office who someone's told them they have lupus and they don't, okay, and then it works the other way as well. So there's no single test that tells whether someone has lupus. It's sort of a combination of several things, and that's what makes it, I think makes it tricky. So, other things, questions?
How did you get interested in this?
Yeah. In my training program at UT Southwestern, they had a clinic that was specific for patients with autoimmune connective tissue diseases like lupus. Lupus has some sister diseases, dermatomyositis, if any of you have heard of that, scleroderma. Okay? And so in this clinic, we would just see those patients. And so every week I would go and see these patients and really found out that there was a real need, that these patients were, had a hard time getting the care they needed in a lot of places. And so that this was, one, a real opportunity to hopefully help people. And two, I just found the conditions themselves and the idea that you could look at the skin and tell things about what was going on in the inside.
Sorry, the information you gave about the breakdown of how the different types of lupus with skin, is that standard across the board how most dermatologists look at it?
I think it is. I think some dermatologists have very different practices, obviously, and those types of practices may lead them to see more or less cases of it. Like anything, you get better at something the more you see it. Right? And so lupus isn't common enough that the average dermatologist is going to see it real frequently. But it really is the combination of clinical features plus often a skin biopsy is real helpful to determine is it lupus or is it something else. So, I think that dermatologists in training are learning about it. It's just a matter of whether they're seeing it enough to sort of keep up with it. So.
A question regarding vitiligo, actually.
Yeah.
Just because my wife theoretically has it. They found it when she was 14, and in a little packet of vitiligo that she kept from years ago, I was reading and saying one of the causes of it was autoimmune. Do you see that vitiligo is actually,
More
a
common
symptom of lupus, or is it that her vitiligo is just being misdiagnosed as one of these other
Good question.
conditions?
Good question. We tend to think of all autoimmune diseases being a little more common in certain families, and so patients that have autoimmune thyroid disease and so forth may have relatives who are at higher risk for lupus. Vitiligo has not directly been linked to lupus. I do see patients with some forms of lupus, particularly that middle form, that subacute cutaneous lupus, that it essentially bleaches their skin to the point where it looks like they have vitiligo when they truly have lupus. Yeah, so I think you're onto something there.
Well, since I have you here, I've always kind of wondered that, because it doesn't seem to be growing. I know that the vitiligo is supposed to keep spreading.
Vitiligo can get to a point and then kind of stay.
But hers just stays. And it seemed a little like some of those pictures you were seeing.
Usually, there would have been, if it was lupus, there would have been some preceding activity or redness besides just the white patch. But children's lupus.
So could that be aggravated by heat, or is it different if it's aggravated by heat than sun?
Good question. It really is a little bit different if it's aggravated by the heat. Sometimes, once it's well established, then heat could aggravate it a little bit. But classic lupus pernio is sort of worsened more by the cold than by heat. What we call chilblains lupus. Now, people can have lupus on their hands and feet that's not necessarily that type of lupus, though, too. So if it's worsened by sun or heat, it may be a different version of lupus. So, anything else?
No.
Yeah.
Along the lines of that question, because my wife does suffer from the cold version of it. She's got the Raynaud, so rain all over with it, and then she's also got lupus where when her feet,
Right.
hands get cold, it certainly causes
Breaks
a
out.
red, and the toes get all, red like that, and then eventually turns like a sore or whatever. What can she do to really help stop that?
Real aggressive cold prevention. Okay, so just it's the same with Raynaud's. Hand warmers. Okay, you can buy those at REI. Once you break, you put in your gloves. Steering wheels are a common cause of it in the winter. You get in your cold car, and you grab the steering wheel, and it's cold. So sticking your hand in the freezer, obviously, can cause attacks. And then antimalarial medicines are not that helpful, unfortunately, for that particular problem. There's a blood pressure medicine called a calcium channel blocker that's used to open up blood vessels some and help better blood flow in the cold. That can be helpful. Sometimes it's very difficult to control. We use some of those stronger medicines even. But
is there a temperature where it tends to kind of start getting activated? So it's outside, it's at 50 degrees. This is where it kind of starts to happen.
It's a little different in everyone, but typically it's about 45 degrees or so or lower. And if it's damp, that seems to make it worse. Okay? This is the biggest problem in England, actually, because of the cold and damp together. So, all right, thank you very much.